Let's turn to our next speaker, Dr. Wasim Firuz, who's Deputy Medical Coordinator of MSF in Bangladesh, who will give us a highlights of the MSF response to this HCV epidemic. Wasim, over to you.
Good afternoon and good morning, everyone. Am I audible?
Yes.
Okay, this is Dr. Wasim Firuz. I'm the Deputy Medical Coordinator from MSF Bangladesh. So in this next few minutes, we'll try to explain what MSF has been doing in this Rohingya camp regarding this hepatitis C for the last few years. So currently, MSF we are working in this Rohingya camp for a very long time, and especially after this recent influx of 2017. Currently, MSF, we have total 3 field hospitals, 2 primary healthcare center, and 4 health posts in the Rohingya camp. So back in 2019, in one of our health facility, we have an NCD cohort, roughly 2,500. So while treating this one chronic disease, mainly diabetes and hypertension, and we're seeing this cohort are very well maintained, despite they are repeatedly admit, some of these cohort patients repeatedly admitting in our hospital. And when we have analyzed in one of our hospital database, we have seen roughly 10% of total admission, and almost 20% of our ICU admission are due to decompensated liver disease. And when we have analyzed our mortality data, it receives that amount 20 to 22% total hospital death are due to hepatitis C, some hepatitis B related complication. So at that time, a thought comes to our mind, like this cohorted patient where we're taking their chronic taking care, why don't put another component, so another chronic disease which is communicable. So based on that thought, we start some kind of a random survey in our IPD and OPD patient, which give us a 19% seropositivity. It was, we tested for a couple of days, and it is 105 Hep C RDT positive out of 546. And by this time, we kind of identify this as a hidden communicable threat to our NCD and IPD patient, as well as for the total community. After that, in October 2020, MSF, we have come forward for providing hepatitis C treatment, initially with this NCD patient and the critical patient who has been admitted to the IPD. So at that time, we are considering that as Dr. Bashanti clearly said, in Bangladesh, the hepatitis C prevalence is less than 1% among the Bangladeshi nationals. And we do not have that much experience, at least the Bangladeshi doctors, in treating hepatitis C. So at that point, we bring out this MSF real world learning. And before that, in the last recent 10 to 15 years, we have been operating hepatitis C program almost in 15 camp, and one of the biggest is in Cambodia, which we ran hepatitis C between 2016 and 2021, and another is Pakistan, where we have run hepatitis C campaign 2015 to 2024, and we have treated roughly 29,000 patients in both projects. What we have learned from our Cambodia project, so in this project previously, in the beginning, we learned very extensive program. We used to do the genotype, we used to do the fibroscan, we do the upriscore and everything. As MSF work most of the time in low resource setting, gradually we are trying to get, okay, how it can be more affordable for the population, also operationally sustainable. And between 2016 and 2019, we exercised different model in Cambodia. And every time we have seen there is sustainable virological rate between 97 to 98%. This gives us a confidence that it can be managed in low resource setting, and we come to this learning from our Cambodia project that visit can be reduced to between 5 to 8. We can avoid the genotyping by, as we are now using the pan-genotypic drug, we can reduce the test only for the selective patients. And for the defining between 12-week regimen and 24-week regimen, we can rely on our clinical suspicion. And as we do not have a lot of opportunity to directly communicate with the hepatologist, so this model helps us to continue activity in low resource setting. The basic difference between the WHO model and MSF model is we don't do a lot of tests. What we do, we basically do the RDT of the suspected case. Then if RDT positive, we go for the confirmation by PCR, and we use our Gene Expert platform here. And then if PCR positive, we do a clinical assessment. So mainly we check if patient is decompensated or not. So ascites, jaundice and hepatomesis or hepatic encephalopathy. And if there is no symptoms, we go for 12 weeks regimen. And so the main difference between WHO and us, we avoid some additional tested, and we mainly based on clinical judgment how to decide between 12 weeks regimen and 24 weeks regimen. So then between 2020 to 2024, in the camp, MSF is the only organization who are dealing with the hepatitis C. And between this time, we have 2 facilities, and our capacity was a bit minimum. So in one facility, we able to enroll 150 patients per month. And in another facility, we able to enroll 15 patients per month. During these times, as the demand was enormous, we have to come up with some kind of criteria. So mainly how we have prioritized, we prioritize our patient from the NCD cohort, then patient with signs, symptoms of decompensated cirrhosis, any partners of the patients in our mental health cohort, and patient with co-infected with HIV and hepatitis B. And especially if any patient requires any surgical intervention, we've also tried to prioritize them. After that, if we have Rome, then we are prioritizing the patient who are more than 40 years old, who have been presented in our hospital. And this is our criteria, as I have already explained. We used to do the hepatitis C RDT. Then if positive, we check the viral load. If viral load positive, we check the clinical signs of clinical decompensation. If there is no, then we go for 12 weeks treatment. And if yes, there is clinical sign of decompensation, we go for 24 weeks treatment. The advantage that it increases access to care, and it gives us further decision making and reduce the staff workload. So we placed a very few medical visit for the patient, and it is remained between 6. If there is 12 weeks regimen, we have patient has to come 6 times in the facility, and if it is 24-week regimen, they have to come additional 3 times in our facility. Between 2020 to 2024, we have screened total 30,000 population and enrolled more than 10,000 patients. And we have seen almost 99% of the patients, they have completed their treatment. And in terms of our cure rate, we have 94% cure rate, both in the 12-week regimen and 24-week regimen. Then, as we have already completed our NCD patient and our IPD complicated patient, we are checking like how to open our cohort for the population. At that time, back in 2020, there was not a lot of study or evidence generated in Bangladesh, but gradually we have seen some study has been published. But we would like to check the prevalence of active hepatitis infection. So by this, we ran a seroprevalence study back in 2023 mid. And what we have found that also supported some of the previous studies. So we have seen that the seroprevalence is 29.7% and the active HCV infection is 90.6%, which means nearly 1/3 of the adult population that has been exposed to hepatitis C in their life, and 1 in every 5 adult population, they need active hepatitis C and they need treatment. Besides, also what we have seen, there is higher seroprevalence among the females, according to all ages, and lower seroprevalence among the young adults. And when we have estimated, based on that time available UNICEF population data, we have estimated there are 85,000 adult population who have active hepatitis C and who need treatment. So that back in 2024, also WHO has been come up with their hepatitis C surveillance. And then based on our evidence, we have planned for scaling up treatment. So MSF planned for additional 30,000 treatment for completing within 1 year. And we planned additional hepatitis C treatment center. And we proposed extensive health promotion, community level screening, and our approach was camp by camp approach. And the target we take, the dedicated MSF camp, we will bring 90% of the affected patient under treatment. So this is our diagnostic approach. Initially, MSF, we planned for 9 camps. So on these 9 camps, we will do the mass screening and we'll bring them all positive patient under treatment. Later, we have take additional 2 camps, so total 9 camps. And our screening criteria was all adult population and the index case. Like if any child of that particular parents who are positive, we are bringing them under the screening approach. And we are doing community level screening, camp by camp approach. Initially, we have 3 teams. They started 3 camps at a time. And we are doing same day sample collection for the PCR. And then we are running it our Gene Expert platform. And within 24 to 48 hours, we are initiating the hepatitis C treatment for them. So that is a bit unique, our community-based screening approach. So we have followed 2 models. One is door-to-door approach and one is Sentinel site-based approach. In the door-to-door model, our hepatitis C team member, mainly the nurse and Rohingya community-based team member, they are going to every door and they are screening the family member, going to the family. And in the Sentinel site-based approach, we are doing a bit more micro things. So in the camp, the distributed is around, each camp is consist of some block and each sub block is consist of some sub block. So we have been engaging with the community. We are meeting with the community leader, Machi and Imam, and we are asking, you don't need to come to the facility. MSF will come to closer to you, but you have to give us space. So they give us some, one day they give us a mock top, one day they give us mocks for 2 to 3 days. They have been seeing some picture on the right side. And we are doing the screening on that particular subject to reduce the community mobilization to the facility. And at the same time, when there is RDT negative, we are doing health promotion, how they can keep negative and how to prevent this. And if positive, we are immediately taking the sample and we are asking them to visit our clinic within next 24 to 48 hours. So this is the achievement of our hepatitis C test and treat campaign between April 2025 to March till now. Out of 11 camps that MSF assigned, we have completed screening in our 9 camps and 2 camps is ongoing. We are planning to complete those screening by next 1 and 1.5 months. In terms of RTT coverage, in the presented adult population in this particular camp, we have reached closer to 90% RTT coverage. And so far, we have screened roughly 150,000 population, and we have seen there is a 90% seroprevalence. Our PCR coverage is 100%, and PCR positivity is 28%. So the viremia is around 13%. And we initiated 16, almost closer to 17,000 population. There are few pending, mainly they are pregnant and breastfeeding, lactating women. Among the completed patient, we have did 8,000 SBR12, and so far our cure rate is 94.6%. So what we have seen, there are task force has been developed. There are other health workers, partners who have been doing also the things. And we can say that our simplified model can be adapted to scale up the things. And we will propose to hepatitis C integration in the general healthcare package. One of the things, though MSF completed the screening in their particular camp, there are other camps which need to scaling up the capacity to complete gradual screening. And another things we have been worried, the prevention and reinfection. We have already started to see some reinfected case. And as there is still quite some traditional healer, as Dr. Bashanti said, there are some traditional healer, there is unauthorized practice, unsafe practice of needle ongoing. We need to prevent this. And there is still a question, we have some pregnant and lactating women, though that is widely not recommended to treat the pregnant and lactating women. We have a bit afraid if they might be lost in the follow-up. And at the same time, still, though there is 94% cure rate, there is 6% failure rate. So, so far, not within MSF or WHO, we don't have an answer for this population. And for the facilitating global access, we will propose to look for alternate, cheap, but effective, low resource conformative tool for the low resource setting. Thank you.
Thank you very much. Again, I encourage you to submit questions in the Q&A, and then we will be exploring this presentation in more detail during the discussion.